Good morning, everyone. Welcome to Grand Rounds this Thursday morning. I'm Ava Kadiwada. I'm one of the medicine chief residents this academic year. This morning, it's my pleasure to introduce Dr. David Carr. Dr. Carr is the Alan A. and Edith L. Wolf Professor of Geriatric Medicine in the Department of Medicine and Neurology at WashU in St. Louis. Dr. Carr is a clinician in the Memory Diagnostic Center and Geriatric Assessment Clinic at WashU, where he maintains an outpatient consulting practice in dementia and geriatric care. He does research on dementia and driving in the Knight ADRC and is the site PI in the graduate trial and the Green Memory trial in the WashU Alzheimer's treatment unit. He has been and is currently the principal investigator or co-investigator on research national guidelines and or educational initiatives related to medical conditions and driving. This morning, he joins us to discuss a clinical and research update on Alzheimer's disease. Thank you so much, Dr. Carr, for being with us this morning.
Avi, thanks for that nice introduction. Glad to be here and looking forward to covering a few topics that are near and dear to my heart and hopefully yours too. Just wanted to make sure I had my disclosure slide. Probably most pertinent to this talk is that I am a site PI for the graduate trial and the upcoming Green Memory trial. And so certainly want to be aware of any conflicts of interest there. So over this next 45 minutes, hour, let's just talk a little bit about how we differentiate normal age-related changes in cognition from this gray term we call mild cognitive impairment versus dementia, or the major neurocognitive disorder. How do we, in 2021, diagnose and treat Alzheimer's disease? We have AD biomarkers. We'll go through some of those, but certainly one can make the diagnosis with or without them, and we'll discuss some of those opportunities and pitfalls, if you will. So much research going on, hundreds of compounds being studied across the globe. Our focus, at least a good deal of it, has been monoclonal antibodies. So when we get to the end of this talk, I'll focus in on where we are with that and the current drug that's before the FDA for possible approval. I would be amiss if we didn't talk about the huge numbers that we have here that we are dealing with. I usually like to mention in 2020, if you picture greater St. Louis area, 2.5 million or more, think about twice that size, the number of people we currently have with dementia-related disorders in the United States. Currently, it's the 75 to 84 group, but as you can see in this projection, by Herbert et al., that by mid-century, if we're not able to curtail this disease, modify it, arrest it, we're about going to triple the number of people. So if you already think you're seeing a fair number of demented older adults in your practice, whatever that practice may be, primary care, subspecialty, and hospitalization, outpatient, you're going to be seeing 3 times as much, and especially the oldest age. So when we get to 85 and older, that's going to be the majority of patients with a continuing aging demographic. Sort of a tsunami of Alzheimer's patients is upon us. But we know it's not just our patients, and the reason we see a lot of our folks in clinic and have our challenging struggles in the hospital is how we care for them and who cares for them. And the caregivers and caregiver burden is a huge issue. And over 16 million people are providing care for demented patients in the United States, probably close to $20 billion of unpaid care. You look at the costs for our society are well over 300 billion estimates, and it's going to be up over $1 trillion by mid-century. So it is a breathtaking disease just from sheer numbers. We're getting crushed. All the more reason why NIH, pharma, et cetera, continues to put efforts and monies into treatment. One of the questions that often comes up for all of us as physicians is, how do we recognize a patient with dementia? And I think we got very good in the first couple decades as we became familiar with the disease, especially Alzheimer's disease, about episodic anterograde short-term memory, that people like to repeat themselves, and they like to repeat themselves within minutes, et cetera. And so We typically think of the medial temporal lobe and the hippocampi and areas that subserve, retaining new information. But it's a big world out there of neurodegeneration, as you know, and the brain can go down in a variety of different areas. It can be the frontal temporal. We'll get to that just in a little bit. You can have issues with attention and executive function, planning, sequencing, processing speed, if you will. Parietal lobe and occipital lobe can go down. This tends to freak patients, families, and clinicians out very early because people will, maybe they don't recognize a spouse very early in the disease or recognize their environment. So clinicians need to be aware that although short-term memory is certainly a common presentation of brain disease, it is certainly not the only one. And we need to know the different cognitive functions of the brain and realize they can affect occupation, activities of daily living, and our behavior and social comportment. When you think about changes in neurodegenerative disease, some people will start out with behavioral, et cetera, psychosis. They may get labeled schizophrenia or bipolar. They may have disinhibition, hypersexuality. And so clinicians just need to be aware. People can have a primary progressive non-fluent aphasia. They can have a semantic dementia with words. So just to be aware that we have a lot of different ways that we need to have our antennae up, if you will, to find out what's going on. And even though 70 or 80% of the time we do conclude it's Alzheimer's disease or related disorder, it's a big wide world out there. There's a lot of different ways the brain could go down, whether it's hepatic encephalopathy, vasculitis, the list goes on. And I do think from an internal medicine and neurology standpoint, keeping these differentials around is important. I think I've come to believe in my 30 years of practice that it's rare that it's just neurodegenerative. It's not uncommon to have depression or a sleep disorder or medications. And I think the clinical pearls are one of the things that will differentiate you from others is sort of what we call the multifactorial, or there certainly can be more than one thing going on, and there are probability statements. You have to figure out, which of those do you think are contributing and what aren't, and really hone those down. So as clinicians, and especially as geriatricians, we love little screens, and we like to be able to detect diseases. And I would recommend to our primary care physicians, our residents, and those that are on the front line of working up dementia, to consider these two screens, if you will, in your armamentum. We're finding out a lot about sleep and brain disease. A lot of elegant work has been done in Dr. Holtzman, our chairman of neurology's lab, Dr. Music, and Dr. Lucy, and many others, and how circadian rhythms may predate some of the changes for amyloid deposition and tau. And so it may not be surprising that there's high risk association with obstructive sleep apnea, OSA, and Alzheimer's. In fact, if you're diagnosed with OSA, your hazard ratio for getting Alzheimer's disease in the next 5 years or so is about 4. I mean, it's high. And there are so many people with Alzheimer's disease with OSA. So there's a tie there. And so having a screen where you're looking for sleep disorders, diagnosing and treating them, I have no doubt has the potential, short or long term, to affect the trajectory of a neurodegenerative disease. We have some data on that. We certainly need more. Some people use the stop bang for, that's very, I think, specific for sleep apnea. For 30 years, I've used the Epworth Sleepiness Scale. You get a score greater than 10. I refer automatically to the sleep clinic. In fact, I've reduced my cutoff to 8 now, since I've never had anybody I've sent to the sleep lab with a positive screen of 10 or more that has not had an abnormal overnight polysomnography. The Epworth was going to capture more than, you could have a run behavior disorder, maybe you've got restless legs, you've got other issues. If you got somebody in a benzo and they're sleepy from that, obviously you may not go right off to sleep lab, but you get my idea. I can't emphasize enough as a clinician, assessing and talking about sleep and trying to make it better for an older adult. All right, I'll get off my sleep box or my soapbox on that one. Let's move over to the APE2. I have to tell you a very sad story as a clinician. So in my neurology clinic, I'm not a neurologist, but I kind of get to play one on TV. And I'm surrounded by my colleagues in neurology, Joyce Schneider, et cetera. And I went through a phase where I was ordering a fair number of autoimmune antibody panels to look for autoimmune encephalitis. And the guidelines we had back a few years ago were, I won't say they were vague, but they were pretty all-inclusive. You know, somebody had weight loss, psychiatric problems, et cetera. And that kind of is about half my practice. So I was sending off a lot of these antibody panels at a huge cost. And, you know, you send off an antibody panel with 20, 25 antibodies, odds are one of them is going to come back positive. And it's probably a low titer. And it's probably a false positive. But when it comes back, you're obligated for many of them, because it can be associated with malignancy, to doing a whole body PET scan or a whole body, you know, CT. And then there's a radiation with that. So you're chasing malignancy. And then you need to go on and get your LP to look to see if you've got white cells, inflammation, and any positive titers there. So I worked up a lot of people that really didn't need to be. And thankfully, Dr. Buccelli and one of the neuro residents started doing a quality assurance study, probably just because of me. But others, we were ordering too many of these tests. And it's just been a really nice, validated questionnaire here, where you really need 4 more points to justify getting your serum AIM panel. So I just mentioned it's to be considered. You know, we tend, because we're academic, we think, oh, what's in the differential? But we really need to be good stewards of our labs and what we're ordering. And so a lot of these points here have to do with seizures and uncontrolled seizures and rapidly progressive conditions. So it's really cut down on the number that I've ordered. And I just, again, recommend that to use a formal screen if you're thinking about somebody who's had rapidly progressive dementia, has a seizure disorder, autonomic dysfunction, then, you know, maybe something to be considered. I will say, though, if you score 4 more on this screen, then you're obligated not to just to get the serum, but also to proceed with an LP and do CSF studies. All right, so enough about the workup to get us to Alzheimer's disease. When somebody comes in, I do try to categorize them into 1 of 3 sort of situations. You're the worried well, your memory's better than mine, which may not be saying a lot. You have age-related cognitive changes. I'll talk about those. Or your cognitive change is interfering with your occupational, social, or ADL function, a dementia, or we're somewhere in between, mild cognitive impairment. So, and every person that comes in, I do try, I'm not always successful, but I try to give them sort of this phenotypic label, and that starts the differential and our path to Alzheimer's workup. So what are common cognitive concerns older adults have? Well, they walk into a room and they forget what they were going to do. Who hasn't been there? They'll be in a conversation, they'll have trouble retrieving a proper name. They may feel like their reaction time isn't as quick. They may feel like they can't multitask, text and drive like they used to. Just kidding, don't do it. In any event, the point is, those are common cognitive concerns that typically are not associated with functional impairment, age-related changes, and they don't interfere. And so those, we do see people, we reassure them from that standpoint. On the other hand, we definitely see individuals who have no longer can do their job, are having difficulty with higher order cognitive tasks, typically driving, cooking, finances. Those take a lot of frontal lobe executive function tasks, or they may have behavioral social issues that are interfering with their relationships. But in between, we have this mild cognitive impairment, or MCI. And I think it is important to make a diagnosis. And how do we do that? So originally, Peterson at Mayo et al. And others came up with either a patient or a family member has a cognitive concern. They're not demented. We can objectively test for that. But there's no impairments in their activities of daily living. And you can have more than one cognitive domain. So let's just flesh this out for a minute. So making a, quote, MCI diagnosis. We ask questions regarding short-term memory, language, attention, visual spatial abilities, executive function. The concern can be from an informant or collateral source. You know, research definitions, we have all these fancy research tests. When we do our testing in geriatric assessment clinic or memory diagnostic center, we have psychometricians or caseworkers that do extensive testing, help us out. But really, you can get a lot done with a short blessed test and a clock. If you have time to do the MoCA or the mini mental, they're copyrighted now, and you know they take time. But obviously, if you could get additional information, it's good. But you need to see, is there a lining up of your concern of change in cognition with an impairment in one of the cognitive domains, and then a relative preservation of functional abilities. So you know it takes time, but we like to ask, how's their driving, how's their cooking, how's their shopping, taking medicines, and there are questionnaires for that. I'll come back. 88 is a brief cognitive screen that does ask some functional questions. And there's some formal assessments, but I think I've been impressed. You know, most of us can whip into that pretty quick. And then, but there's no impairment in social or occupational function. Now, what I find interesting, so some key points about MCI. It does require the relative preservation of functional ability. So I get to review a lot of articles on MCI and driving, and you know they cite that you know there's driving impairment with MCI. Well, I would argue it's a little bit of circular logic, but if you have an activity of daily living that's impaired due to your cognition, that's not MCI. We may be parsing words here, but that is a dementia. And so again, I think we got to be careful on how we throw the terms around. I think it's fair to say if you have a progressive cognitive decline, especially if it's episodic, anterograde, learning new memories that are lost, we feel very comfortable saying MCI is Alzheimer's disease. And that's always a tough one when somebody hasn't gotten to the point, but many of us feel comfortable with that. Now, there's a lot of people who come in who are impaired, and I don't know why they're impaired. I have some suspicions, maybe sleep disorder, maybe a vascular cognitive impairment, maybe Alzheimer's disease. But there's a lot of people who we feel very comfortable likely have it. Right now, no pharmacological intervention has shown efficacy. There's a New England Journal of Medicine article that looked at a 3-year study, and there was no difference in time to onset of the disease. No shocker, because the drugs we have are mostly for symptomatic treatment, are not getting at the pathology of the disease. There are some studies that show exercise, you know, cognitive training may have some benefit, nothing proven, but at least has some potential. And also realize that it's not all about memory. Some people will, I've seen people with primary deficits in language, attention span, visual spatial, recognition decline. And so sometimes referral can help. I won't go through this whole slide, but when it comes down to it, diagnosing somebody with the general phenotype of dementia is still a clinical diagnosis. We look at interference with work, usual activities, a decline from previous function. We don't have to have neuropsychological testing. You can detect it with some of your history and your screens. And I think there's probably been a less of an emphasis on 2 or more domains. I think many of us feel comfortable making a diagnosis with one domain, especially if they impair activities of daily living. Now, before we jump into Alzheimer's disease and the biomarkers for the next part of the talk, this isn't a talk on the other common neurodegenerative disease, but it is important to recognize them because their clinical course, their progression, and their treatment will be different. And just briefly, if you have a rapidly evolving dementia, somebody's declined. I had a gentleman who came into my clinic a year ago, December, or 2 years ago, December, came back from his vacation, didn't recognize his neighborhood, walked in the house, didn't recognize his house. Everybody was freaking out. He came in, and he definitely had posterior cortical dysfunction. I saw him in January, and he died in March from CJD. Now, there are people who have a much more slower, insidious course for visual recognition, et cetera. But I think you just have to be aware as a clinician, are things going down quickly? Let's work it up and work it up quickly. Vascular cognitive impairment, I'm not going to spend a lot of time on, but we certainly don't see much multi-infarct dementia because stroke neurology sees that. It's out there. There's no doubt people have discrete strokes and have decline. Be aware of that. I'll get to the white matter disease issues in just a little bit. Lewy body dementia with frequent falls, prominent psychosis, Parkinsonism, REM behavior, sleep disorder, I think is, when it's all there, is pretty obvious to detect and may really impact your treatment decisions. So important to try to differentiate that out, although it's fair to say pathologically Alzheimer's and Lewy body, cortical Lewy bodies often go hand in hand. And then FTD, we often see in our 50 and 60-year-olds with either primary language or behavioral issues. So I think just to be aware as a clinician that there are a lot of different presentations, and that may be when you might consider a referral. So I get asked, and so I give a fair amount of talks to our residents and primary care physicians, what can we really get done in the outpatient basis? What can we do fairly quickly and efficiently? Because, what do you have? You have 15, 20 minutes maybe for a patient, and you may have to split it up. But, in 10 or 15 minutes, I can get a good history from, and again, I would suggest the informant or the collateral source. Some people don't like the term informant. I got bawled out one time at a lecture for using that term. But, you ask about the cognitive domains, short-term memory, executive function, language, like, you mentioned. If you have time to whip out the MoCA or the mini mental, do it. But if you don't, a short blessed clock drawing task, you can get a lot of information on some of those cognitive domains very quickly. There's lab screens that most of us feel are sort of basic to get our B12, thyroid, RPR, HIV, CMP, CBC. Use your screens. If somebody's hypersomnolent, they're falling asleep while you're talking to them, like during a Dr. Carr lecture, screen them with the Epworth. And if they get a score of 10 or more, get them off to the sleep clinic. Or, again, if you talk to them and you're convinced they're having difficulty with sleep at night and daytime somnolence. If you decide to go forward with an MRI, I would order it with 3D volumetrics. And let me explain that. So we started offering, neuroradiology a few years ago, a program called Free Surfer, where they actually measure the amount of cortical thinning, if present, and compare them to age-matched controls. They also measure the amount of white matter disease. It's called the Physika score in mild, moderate, or severe. Now, why is this important? Well, to give you an idea, sometimes people come in and, it's not quite clear, is it Alzheimer's disease? Is it not? And one of my recent patients from last month had some vascular disease, but it wasn't quite clear to me if they had Alzheimer's. And if you just take a look at this reading, and these are measurements of the different types, areas of the brain and their cortical thickness. And here we have the left hippocampus is in the first percentile, greater than 2 standard deviations below the mean. The right is also. So here we have a couple of hippocampi, there's nothing left of them. I feel pretty confident when I get an MRI reading, if it's down around 1, 5, 10, 15 percentile, that we likely have some neurodegeneration. And if that lines up with your history and exam, I feel very comfortable with the diagnosis. Lewy body dementia typically will have more parietal occipital cortical thinning. And so I'll see somebody with some posterior cortical dysfunction and psychosis, they'll get an MRI with 3D biometrics, not uncommon, they'll come back in the 1/5, 10th percentile of their parietal occipital lobe. So I do think it can help characterize and confirm the phenotype, the clinical description that's going on. And then what about this ubiquitous white matter disease? We see this a lot, and people say, well, that's just common and that sort of thing. So a few things about it. And if you'd like some articles, just email me and I can send them to you. So first off, what are these? So we do think, and especially in our older adults, they often come down to either atherosclerosis, typically hypertension, or cerebral amyloid angiopathy. And it's ischemia. I mean, pathologically, if you look at these areas under the microscope, they typically, there's axonal loss, demyelination, gliosis, and so areas of function. And if you look at clinically, when you assess people, they typically have slower processing speed, impaired executive function, gait and balance problems. So I'm typically reluctant to attribute a classic Alzheimer's patient with short-term memory impairment, progressive decline, to this. But if I have added executive function impairment, urinary issues, gait balance issues, I think there can be a contribution. In general, the periventricular and more juxtacortical areas are probably more cerebral amyloid angiopathy. Areas that are a little outside the ventricles tend to be more related to hypertension, deep white matter. And they can be non-confluent and confluent. But again, when you get your MRI with 3D biometrics, you will get both a measure of your white matter disease and a measure of your cortical thinning. Now, another question comes up is, when you refer to geriatrics, when you refer to psychiatry, when to neurology? And the reality is, in the hospital, we get consults, all three services, outpatient, there's overlap, sure there is. But what I like to at least explain, a typical geriatric patient would have multiple medical problems. They may have geriatric syndromes, maybe weight loss, failure to thrive, maybe polypharmacy, urinary incontinence, falls. So that sort of patient that has complex psychosocial situations, that is a sort of a classic patient to consider referring to our outpatient clinics or in the hospital for a consult. Now, if they have primary behavioral issues, depression, anxiety, psychosis, perhaps psychiatry would be a good referral. And then if it's, a younger person, FTD, maybe a Lewy body, maybe an atypical, rapidly progressive, neurology. And again, we'll all see these patients, but I think it's important to know where to go and how to go. And, the wait times can be long, but I would say if you're having difficulties, please email me. And there's often more than one way to get someone in. I know it's not easy. All right, so that was the second part in regards to some of the workup and the things along those lines. Let's say you've diagnosed somebody with dementia, and now the question is, the biomarkers that are available, should you bring those out or not, or can you, and are they reimbursed? And how helpful are they if we use them? So going back in the day, Dr. Alzheimer diagnosed Gus D with strange behaviors, suspicions. Apparently, she had a suspicion her husband was cheating on her. Apparently, that turned out to be true. So just remember, in your psychotic patients, sometimes everything they tell you may not necessarily be false. So in any event, and the classic plaques and tangles, and probably better described in this picture here. So the amyloid plaque is extraneuronal, outside the neuron, and it's typically the A beta 42. We see the A beta 40 in more of the amyloid angiopathy as the predominant protein in that situation. But A beta 42 is felt to be toxic and can contribute to dystrophic neurites, cause an inflammatory reaction where you get microglia, astrocytes, and a fair number of mediators here, which can contribute to neuronal injury. Over time, as these plaques continue to, at least this is the thought or the amyloid hypothesis, if you will also start accumulating downstream abnormal protein within the neuron. So the tau, and more specifically for Alzheimer's disease, the phosphorylated tau. And eventually, this can impair the cytoskeleton and contribute to neuronal death. So when you look at the last 2 decades or so of Alzheimer's research, a lot of it has focused in on either decreasing the production or increasing the elimination of the amyloid plaque, or trying to reduce the creation or contribute to the elimination of tau protein. And certainly there are anti-inflammatory mechanisms that people will look at. So how do we image amyloid in the brain? So that used to be done by a compound initially from Pittsburgh compound B, PIB, and these compounds that bind to amyloid have to be made in a cyclotron. They have a very short half-life, so they're not clinically very difficult to use. And but we found out early on that individuals that had PIB scans would bind amyloid and be positive. However, most of the Alzheimer's centers across the globe found out if you did these PIB PET scans on cognitively normal older adults, about 30% over age 70 would have positive amyloid scans. So, and sure enough, you follow people over time, they often end up with an Alzheimer's dementia. Now, PIB wasn't clinically too useful given its short half-life, and so a longer one by the name of florbetapir was created and eventually was validated in a couple clinical studies. And what the FDA insisted is, instead of having sort of a negative, positive, and intermediate, just a positive study or a negative based on the amyloid binding. And of course, there are, for research studies, quantitative ways to measure the amount of amyloid binding. But in this depiction, you can see a positive test compared to negative for the what we call the Amyvid scan. We'll get back to its cost and utility. Many of us, both in neurology and geriatrics, as dementia specialists, were invited to participate in a huge study that Medicare participated in called the IDEAS study, the Imaging Dementia Evidence for Amyloid Scanning study. And this was performed back in 2016 and 2017. Over 16,000 patients had to be seen by a dementia specialist. And basically, it had to be a situation where you were uncertain, you knew they had a cognitive decline, Alzheimer's was a consideration, but you weren't confident, and getting the PET scan would change your diagnosis and management. And so almost 1,000 dementia specialists were involved in this study at over 600 sites. And this was published this couple of years ago, or a year and a half ago, in JAMA. And basically, what they did find is that there was a change in management more than half the time, about 60% of the time for those that were labeled with MCI, and 60% of the time with dementia. So most of the changes had to do with Alzheimer's drugs. There was some change in non-Alzheimer's disease drug management, antidepressants or other sort of non-FDA approved drugs. And counseling also increased, probably no surprise from that standpoint. And figure 2 here shows, some of the changes pre and post PET that were positive. What I find kind of interesting is there weren't big changes in the Alzheimer's drug use even after a negative amyloid PET for MCI and dementia. There was some movement, but not a lot. So it's sort of an interesting concept. What's going on here, and why aren't there bigger changes? But even more interesting, my recollection of this study is we probably had about 100 people we referred to this, and I was shocked to find out that about 40%, at least last in talking to Dr. Snyder, of our patients came back amyloid negative. And these were people who we thought could have Alzheimer's disease. And so it comes back to this part about the clinical diagnosis of the disease. You know, in the Memory and Aging Project, when I was a clinician, we'd have 3 hours to work a patient up. But even so, we'd only get it right about 90% of the time. Now, if we call them dementia and they came to postmortem autopsy, you know, they might have an Alzheimer's mimic, a gerophilic brain disease, you know, vascular disease, hippocampal sclerosis, something, but they weren't necessarily normal. But the point is in clinical practice where we only have half hour, 45 minutes, an hour, you know, our diagnostic accuracy is certainly less. And all the more reason why, if we're thinking about giving powerful medicines, monoclonal antibodies to go after these proteins, we have to be darn sure people have the disease. So enter the New Ideas study. Obviously, changing Alzheimer's medicines and having a few more counseling sessions wasn't enough for Medicare to approve Amyvid or amyloid scanning. So enter the New Ideas study, which is starting up. And again, not only in our Memory Diagnostic Center, but we're going to participate in our Geriatric Assessment Center. They're going to basically redo the same study, but look at several outcomes. We're going to get a 12-month claims. They're going to look at hospitalizations. They're looking at emergency room visits and overall healthcare utilization. And I think that's what I think would move the dial on getting these reimbursed. Are they really impacting other more robust, costly Medicare outcomes? So normally, getting an Amyvid PET scan is very expensive, but to alert clinicians, these will be available to us in our clinic settings as an option. All right, well, let's turn to the CSF biomarkers. So, and it turns out it's sort of odd and maybe counterintuitive, but when you measure CSF amyloid in Alzheimer's patients, A beta 42, they're actually low, they're not high. And that may seem a little strange in a brain of Alzheimer's patients that has tons of plaques. But again, we would go back to a lot of this is a clearance problem. You're not getting the amyloid out of the brain, so the CF levels are low. Conversely, though, tau and phosphorylated tau levels are generally very high. So when you do your LP, that's sort of the fingerprint, if you will, of what you would expect. And the clinical characteristics for CSF testing is pretty good, and it's been shown in a lot of studies, especially if you do some of the ratios, tau to A beta 42, you get some pretty decent area under the curves for differentiating, is somebody with symptoms, do they have Alzheimer's or not? So we find that they're generally very good studies. And now we kind of figured it wouldn't take long till there would be a blood test available, and there is one available now. And we'll talk about if there's interest, how to get it, should you get it. But in Dr. Bateman's lab, and Dr. Schindler was the lead author on this study, she took almost 700 patients with underlying cognitive impairment, suspicion of Alzheimer's disease, who had undergone amyloid PET imaging. And basically the outcome was a positive amyloid test. So again, you know, the amyloid test has false positives and negatives by PET scan. So it's sort of a validation of not a perfect test, but a very good one. And they found out that if they looked at age, the plasma, A beta 42 to 40 ratio, ApoE genotype, you could come up with an algorithm that would give you what they call the amyloid probability score. And, you know, often one cutoff isn't suffice. So a lot of times, in order to use all your data, people are looking at sort of trichotomous outcomes. And so Dr. Schindler and Bateman and authors have come up with a sort of a high cutoff where if you get the APS score, odds are you've probably got Alzheimer's disease, at least consistent with positive amyloid PET scan. And then you have a cutoff below where odds are you don't have Alzheimer's disease and you'd most likely have a negative PET scan. And then they have this intermediate area, and they've got more data on positive predictive values and things along those lines. If you want that information, we can get it to you. But again, the first that we know of, blood test, more on the way. I think tau and tau aggregates are coming and out there. So how do we put all this together for all these biomarkers of Alzheimer's disease? We've got PET, we've got CSF, we've got blood. So let me talk about some of the pros and cons of each of these. So the Amyloid PET scan is FDA approved. And obviously you don't have to worry too much if somebody's on a DOAC or warfarin, like you would for an LP. But right now it's almost $6,000 out of pocket. Again, when the new idea study starts in the next month or two, we'll be able to order these without cost to the patient from a short term. Now, one of the limitations, though, is you're only testing amyloid. And you can have a lot of amyloid in your brain and not have symptoms, although, again, the validation for the Amyloid PET scan was on a pretty demented cohort. So, and again, it's a positive negative. So it does make you wonder for the quote negatives if we, missed a significant number of people that might have the disease. CSF biomarkers, well established. What's great about getting LP is you can test for inflammation if you're worried about antibody-mediated encephalopathy, CJD. You can look for inflammation, get these additional tests, especially for rapidly progressive. These are generally covered by all insurances, Medicare and other insurances. The cost for typically beta amyloid, tau, phosphorylated tau, about under $1,000. But the cons are, obviously somebody has to come in, get an LP, and the LP is, of course, done now compared to 30 years ago when we used to use harpoons, very flexible, small needles. We just have a few clinicians in our LP clinic and MDC that do them. They're usually in and out in 20 minutes. Headache's pretty rare for our older adults, but it is, it takes time, and it's also, it's not like you can get people in and out. So there's a sort of a burden, if you will, for the providers. And the biomarkers, obviously, a blood biomarker is great, get a blood test. But it's currently not FDA approved. It's one study. Some might want to wait for further validation. And again, it was validated against the PET, which is, again, not 100%. It's a $1,200 cost out of pocket, a sliding scale. However, again, you have to say, do you want to pay $1,200 and end up in that intermediate level, and you still might need more tests. So again, some limitations. But I have C2 Diagnostics, for full disclosure. I don't get any kickbacks or anything from the lab at Dr. Bateman and Dr. Holtzman's company, vetted with WashU. And if you are interested in more about the blood test, I've got a fair amount of literature on it. I'm happy to email you what I have. You can certainly reach out to Dr. Schindler, but there's a phone number and an email for information up here on the Presymptomatic AD. So when do we consider these biomarkers? Well, I'll do a case in a little bit, which isn't uncommon what we see, but a lot of times we don't know what's going on. Family doesn't know what's going on. It would be nice to get some reassurance. So that may be an indication to get, a CSF or PET testing. We see people with, so familial Alzheimer's disease is pretty rare, less than 1%. And it's an early onset, and typically people are affected in their 40s. And even though we talk about late onset Alzheimer's disease, 60s, 70s above, we do see people with Alzheimer's disease in their 50s and early 60s, but it's not always a comfortable diagnosis for the patient or family or for the clinician, especially a geriatrician. So sometimes because of young onset and we want the reassurance, we'll go on and get biomarkers. If you have somebody who scored 4 or more on your APE2 questionnaire, You can proceed, especially with CSF studies may be helpful, rapidly progressive dementia. And NPH, if you have somebody with a frontal lobe, wide-based, hesitant, apraxic gait, urinary incontinence, memory problems, the way that we're currently working that up is we'll refer to both Dr. Usha in neurology and Dr. Ziffel Dowlinger, the neurosurgery. They have a NPH clinic, and they'll typically bring them in for a few days, put a lumbar catheter in, measure gait and balance assessment several days in a row, and see, do you think they benefit by a shunt? Well, you can also take some CCs off the back and send them for Alzheimer's biomarkers. And if I had a patient with possible NPH that had low CSF amyloid and high tau and phosphorylated tau, I probably wouldn't shut them because symptomatically they probably got AD, or at least they've got a component, and I'm not sure they benefit. And there's risks obviously associated with a shunt in older adults. So this is a common situation that we see in our clinic. 61-year-old, the husband and daughter are concerned about 3 years, so she would have started at age 58. Increased repeating, forgets she's walked the dog, she's no language problems, no visual spatial issues, some trouble with time relationships, never good at calcs and checkbook and bills, but that is really unchanged. Now she's having difficulty shopping, even with a list. She may forget items, have to go back and get things, was driving too slow, got a ticket, may start the laundry, not finish it, less meticulous with her appearance, scored a 24 out of 30 on the mini mental, so a positive screen there. Logical memory, which is a couple paragraphs we typically read to individuals and they have to give information back, was well below the mean. We usually like to see a score of 12 or 13. MRI of the brain was unrevealing. But the patient, especially the family, were very resistant to the diagnosis of Alzheimer's disease. Oh, she was 58. It can't be, as she's so young. And I've had a fair number of people that, they're off to Mayo, they're off to other second opinions, community neurologists, still looking for answers, either in denial or they're just not reassured. So in this situation, we moved to biomarkers. And although this isn't the test, this is what typically will come back for a profile. And we used to send these to Athena. And again, everybody's assays are different. You're measuring very small amounts here, picograms per mil. So, but in this assay, and now we're sending them to these Mayo Adaville testing, is generally you'd see your A beta greater than 1,000, your total tau less than 238, and your phosphorylated tau less than 21. And this profile came back consistent with Alzheimer's disease. And sure enough, the ratio phosphorylated tau to A beta 42, as we mentioned, which is very sensitive and specific for the disease, was positive. So as often in my experience happens in these cases, once we've done this, we've rolled out other things, patient, family have accepted the diagnosis, they're willing to go on treatment, accept the education, go to the Alzheimer's Association. So in those situations, we find things that'll be helpful. So those are some examples of the biomarkers. We're more apt to get the CSF than anything. And now let's spend the last 5 or 10 minutes talking about monoclonal antibodies and where that field is in Alzheimer's disease. Based on longitudinal studies in here at the Knight ADRC and across the globe, we do think the changes, you'll see somebody in your clinic that shows up that are repeating themselves, have short-term memory impairment. But this process likely started 15, 20 years ago with amyloid CSF accumulation, which can be noted by CSF or PET studies. You then can do an FDG PET or a functional MRI and start noting abnormalities in those studies. Downstream, tau levels start getting accumulated. Eventually, your MRI will start showing that cortical thinning and atrophy. Your psychometric tests will start becoming abnormal, and eventually develop MCI dementia. So a couple things might be gleaned from this graph, and again, it's hypothetical, but there's a lot of data to support it, is once you get symptomatic with dementia, look at all the amyloid you have. You got a ton of it. In fact, there's a very poor correlation with the amount of amyloid in your brain and dementia severity. And so, and it may explain why if you start giving people monoclonal antibodies here and you're moving it back a little bit, it may be too late, too much damage is done. It also makes a point is you can have a lot of amyloid in your brain and not have symptoms, right? So I think that's another clinical point that's derived from this. There's actually a very good, not good, but a better correlation with tau pathology, either by scan or CSF, and dementia severity. So you have your amyloid beta proponents that are hitting amyloid treatments, and then you've got your tauists, if you will, your Baptists and your tauists, and who knows, maybe it's a combination. So you saw the cascade here, and wouldn't it be nice if before you even got to MCI, you had some sort of intervention for amyloid here or tau, or maybe when you're just on the cusp of the disease, and can we knock it? Can we stop it in its tracks? Can we slow progression? Right now, what we have is symptomatic benefit. And of course, if we do nothing, we get this disease course without treatment. Regarding dementia prevention, I would be amiss. I won't spend a lot of time on this because I need to get to the monoclonal antibodies. But if you have a chance, pull the report. It's available to you online, PDF. On Lancet had a commission where they had many experts review all the data on what is a risk factor for Alzheimer's disease and dementia. And they came up with risk factor prevalence and sort of population strategies. And this comes up a lot, is what can we do to prevent? And the adult children constantly ask us this. So this is a great read. I think my only criticism of this is they didn't include sleep, and OSA in this is one of the prevention. But they do make the point that there's still a lot of unknown risk factors, maybe up to 60% of the disease. So a lot of different ways for prevention. Top 10, I would say, would be education, community engagement. Some people suggest a Mediterranean or MIND diet, some modest benefit possibly there. Exercise, treating vascular risk factors, reducing obesity, addressing hearing impairment, limiting alcohol, preventing head trauma, stopping smoking, and getting adequate sleep. So to me, nothing's been proven, but I think these are 10 what's good for the heart's good for the brain. So Alzheimer's Association and Memory Care Home Solutions are two community programs that are great for our Alzheimer's patients. And we do have a driving program affiliated with Trissel that you can refer to the occupational therapy program. So I would be amiss if I didn't mention, we just published a study just last month looking at functional association and caregiver assessment of driving competency. But always consider referring to our driving program at Trissel for challenging situations, regardless if it's Alzheimer's or stroke or traumatic brain injury. I'm happy during the question period to talk a little bit about the cholinesterase inhibitors and NMDA receptor antagonists. Again, we're just trying to hold things in check for 6 months, a year, a couple of years. They're not necessarily benign drugs. I'd say memantine, Namenda, much more so than cholinesterase inhibitors, but certainly aren't getting at the disease, and we do expect people to progress. So we've gone through different decades, and it's really been the last couple of decades we've looked at amyloid and tau therapy. And, it takes time, and I think a lot of pharma and NIH haven't been as enthusiastic at studying moderate to severe and even mild Alzheimer's disease because we haven't seen efficacy. And they've backed up to look at either asymptomatic or mildly symptomatic disease. And if you look at senile plaques, one way to go is to look at the different types of monoclonal antibodies that have been created, and these are generally very, very good about getting amyloid out of the brain. But you can also decrease production with gamma secretase and beta secretase inhibitors. Those have been tried with not much success. Eventually downstream you get tau and neurofibrillary tangles and synaptic loss, neurotoxicity, and cell death. So right now, there is a drug before the FDA. Aducanumab is a monoclonal antibody, and although the initial endpoints weren't reached in two separate studies, Emerge and Engage, they went back and did another analysis at a higher level and looked at potential efficacy. So it's been submitted to the FDA for approval, and we'll find out in March if that's the case. If it does get approved, you're going to see infusion centers set up across the globe. This is a summary of some of the anti-amyloid drugs, most of them that have failed, the gamma secretase inhibitors, the BACE1 inhibitors, and some of the trials for the monoclonal antibodies that have also been negative. However, some of the either asymptomatic trials or mildly symptomatic trials for aducanumab, gantenerumab, BAN2401, and the ALZ-801 have shown some efficacy, whether it's in the ADAS-Cog benefit versus placebo, what we call the CDR, some of the boxes, and some of them, very interestingly, has also shown benefits in tau. And I will make the comment, and I've seen some of the data unpublished yet for gantenerumab, but similar to aducanumab, if you follow these people and they're able to tolerate the high doses, you're getting rid of the amyloid. It is pretty amazing. And now, many of the trials are doing tau scans, tau CSF, and those appear to be responding too, which is quite amazing. And the downside of these drugs are generally what we call ARIA-E, which is amyloid-related imaging abnormality edema, which can be symptomatic, and microhemorrhages. And so in order to pick these up, we have to follow with MRI scans periodically. So will we have a new Alzheimer's treatment in 2021? So the FDA panel, advisory panel, wasn't convinced that this should be ready for prime time, but the FDA itself felt it was. And so most of the time they'll go along with the panel, but not always. So we'll find out in March, but I'm pretty convinced based on the data that we're seeing, if this one doesn't get through, I wouldn't be surprised if one of the next ones comes through and is approved. So I'm going to just pass over and open it up for questions. I know I've filled the hour here, but just to mention that there are a lot of trials that we're doing in our Alzheimer's treatment unit or clinical trials unit. The 4A trial for asymptomatic Alzheimer's disease, we probably won't have the results for a couple of years. Trials that go by Trailblazer, Clarity, Graduate, and Embark. So one of the newer trials we're coming up with that we're going to get started here is Autonomy, which is going to be a monoclonal antibody that targets tau. In the Green Memory trial, which is going to alter the gut microbiome and hopefully decrease inflammation. So if there's interest in referring to either our clinic, geriatric assessment clinic, there's a number here, our Memory Diagnostic Center clinic. If you have questions about research trials, Joy Snyder, who's director of the unit, will be happy to answer any of those by email. I would be too, so don't hesitate to reach out. But enjoyed talking. Hopefully this was helpful information to you today.
Thank you so much, Dr. Carr. It was certainly helpful information. I think that as internists, this is an issue that we all see in our clinics, no matter what specific specialty we're practicing. I will go ahead and share my screen just to share the QR codes, and then we can do some questions as well. So we had one question come up that asked, is there a clinically appearing difference between tau-related neuroaccumulation versus amyloid plaques?
So I'll answer that to the best of my ability. I have a feeling John Morris and Joy Snyder could address that. But so most of the clinical symptomatology, as we've seen with the clinical course for Alzheimer's disease, is tau in the presence of Alzheimer's disease. And most of the tauopathies I've been familiar with haven't been sort of a classic Alzheimer's phenotype, but have been more like progressive supranuclear palsy or FTD, et cetera. And there may be some other neurologists attending lecture or other things along those lines. But I would say yes, and they tend to be more frontal lobe and or motor type neurodegenerative diseases than in Alzheimer's, especially when it comes to amnestic or memory presentations.
Great, thank you. Another question is, how do you see these monoclonal antibodies translating into the real world then, kind of like looking into the future a little bit more? It appeared that, these would be more helpful earlier in the clinical course of Alzheimer's disease when perhaps the patient isn't as clinically apparent to have dementia. Do you think that this will require that primary care physicians are more astute in doing these screening modalities that you reviewed at the beginning of your presentation? Or do you think that we'll just be able to at least minimize some burden of the amyloid and see a clinical difference there?
Yeah, so a couple things. I think that regarding diagnostics, I do think you're going to see in the next few years a lot of the blood tests become available that will give you a high confidence that somebody has Alzheimer's disease. And that's not to say if they went into an infusion center, they might need confirmation by CSF or PET. But I think from a primary care perspective, that we're kind of rapidly going from a clinical, history exam to diagnostic testing, which will probably be an addition. But again, I think it depends on what gets approved. If monoclonal antibodies, either amyloid, tau, or a combination, are appropriate for asymptomatic disease, then the question is, diagnostically, how do you detect that as primary care? Presumably it'd be a blood test, it would be a certain level, and then you'd get referred on to an infusion center that would be, run by neurology or a related service. But if you've had symptomatic Alzheimer's disease, my gut feeling again is if monoclonal antibodies do get approved, it's going to be for just mildly symptomatic Alzheimer's patients that are just on the cusp of the disease, MCI. And again, you would get referred in. What's interesting, Dr. Bateman is looked at 2 antibodies for his familial Alzheimer's disease cohort. And these are mutations that cause a rare but young onset. And gantenerumab, which is what we're using in the GRAD trial, he definitely saw a signal not only in getting rid of amyloid, but also assisting tau. And so they're going to do the studies even longer. And I think that's one of the challenges for the monoclonal antibody field is how much can you give without causing the edema and the microhemorrhages, and how long do you have to get it in order to get a clinical effect? And we still don't have those answers yet. Although I think Biogen or whoever makes adenucanab thinks they're ready for prime time. So we'll see.
Yeah, it'll be fascinating to see how that goes along. And then one last question here: is it known that a previous history of head trauma could increase the risk for Alzheimer's disease?
Yes, and if you want a nice review, just pull that Lancet article from last summer. And traumatic head injury, especially with loss of consciousness, does put you at risk. It's mild, but it's there. One of the preventive, of course, areas that individuals or scientists will really push is protection during your biking and your rollerblading, and that you've got adequate protection. And if your child plays football, make sure they have a decent helmet.
Yeah, that's the great advice. Well, thank you so much, Dr. Carr. Those are all the questions for now, and we're already a couple minutes past the hour. Thank you so much for your time this morning. Thank you, everyone, for logging in today, and we'll see you next week.